if you're not calling out what you're testing cranial nerve wise as you go, then know at some point in the middle of your neuro assessment, if that's a system you have to do on your checkoff, that we may say, all right, what cranial nerves did you assess doing that, right? And if the answer is, that'll be points off. Okay, so you have to know what we assess. A lot of these you're able to cluster together. There are techniques where you can cluster multiple cranial nerves together. And then already what Professor Renner was talking about is, and if you have an ENT portion on your scenario and a neuro portion, you're able to knock out a lot of those cranial nerves with your ENT exam, okay, and vice versa, depending which way you wanted to start. And like you said, just by kind of looking, talking, and so on and so forth. So find ways to cluster, to cluster activities together. So I'll show you the way that I do it. It is just a way. It is not the way. There are different ways to go about assessing the different cranial nerves. It's just making sure that you get them all covered in your assessment, right? Also keep in mind with a comprehensive neurologic exam, it's not just the cranial nerves that need to be assessed. We have deep tendon reflexes that need to be assessed and graded. We have motor skills that need to be assessed and graded, and gait. Okay? So that means at some point you have to have your patient stand up, unless you saw them walk into the bay or exam room, in which case you were able to assess their gait as you were coming in to do your checkoff. All right, so cranial nerves, DTRs, motor, gait. All right, okay, so that's going to be all a comprehensive part of your neuro exam. Let me erase this just a bit real quick. You can also see down here the equipment on the ophthalmoscope is a little bit different than the ones down there. We actually have one of these pan optics down here that I was talking about, which are so nice because you can see so much more. So you guys can play with that instead of having the little square head and your wheel on the side and stuff like that. The same principle, but the places are a little bit different. Okay, this is your selector for your different diopters, or this is the selector for the diopters, and this is your focus. So this is the wheel, that's the selector. But you're able to put everything kind of directly onto the eye, and you can see so much. It's just wonderful. Okay, all right. So if you don't mind modeling for me. Okay, smile for me. Stick your tongue straight out at me. Move it side to side. Great. Close your eyes. Arms out in front of you. Palms up. Open eyes. Make two fists for me. Good. Shrug your shoulders up and down. Great. Chin down to your chest. Come back up. Puff out your cheeks. Frown. Good. Wiggle eyebrows up and down. Great. Feel me touching both cheeks. Yep. Feel same on both sides. Good. Push your head against my hand. Great. Same thing over here. Follow my pen or finger with your eyes. Keep your head nice and still. All right. Looking straight at me. Tell me when you see my fingers start to wiggle. Good. Fingers to thumbs, one by one. Go all the way down the line. Great. Relax this arm. Give it to me for just a second. I would take a pen light, or you could take your scope, and you would check pupillary response. Right, good. Step down for me for just a second. Take a couple of steps for me to see you walk. Head back over to the exam table. Great. Before you sit down, just like when I had you sitting up there and I said, hey, close your eyes, arms out in front of you. Do that standing up. Great, open your eyes. Feel like you were standing still, moving around at all. Excellent. All right, done. That's Romberg, by the way. So if you get anybody that comes in and they're having a sort of equilibrium complaint, complaining of any dizziness or lightheadedness or this, that, and the other, you want to do Romberg. Okay? But that's it. That's cranial nerves 2 through 12. That is deep tendon reflexes, upper and lower extremities, 2 plus and symmetric. There's motor skills, and a Romberg, right? So.
So we're not doing like the graph.
When you stuck your tongue out, you didn't.
anesthesia?
I didn't have you say to check
Yeah.
Vegas, but that was the only thing. You could do that with tongue depressor during an ENT exam, but if you don't have an ENT thing, then do that. But I didn't. That was one thing I forgot to do there.
Can you check Vegas by having them swallowed as well?
Yes.
Yeah.
So we don't have to gag them?
Your best. So swallowing. Can you not have a gag reflex and still get something down back into the esophagus? Sure. Right. So best thing is you can if you can do that, and we'll have tongue depressors. We don't have is there any sound down there? No. I don't know if they had any of their overbed tables stocked on any of their checkoffs. We'll have a little thing here with tongue depressors and stuff like that. They'll be able to disposable ones to be able to use and stuff, right? So. But now you can also, like you said, if you're doing an ears, nose, and throat exam, probably half of those cranial nerves are covered in that. So then, if you have the neuro part at the end, you're doing half of what I just did because you're already knocking a lot of that out with your ENT exam component, right? So neuro is probably the least time-consuming system that you will have to assess.
So no sterogenesis or the graphesthesia?
You're not going to have anybody with any major neurofocal deficits. Right? We aren't going to be having stroke or Parkinson's or Alzheimer's or CIDP or Guillain-Barré or MS type kind of folks that would necessitate that. Okay, just a straight cranial nerve assessment, motor skills, deep tendon reflexes.
No sensory.
We won't be having to do any paper testing or monofilaments or this, that, or the other. Okay. So that's what I'm saying. This should be the least nerve-wracking exam.
What did you do for the cranial nerve 8?
I don't know. What did I do for it?
The vestibular cochlear. In the book it says the whisper exam, so I don't know what you did for it.
You do whisper. Oh, yeah. So I should have done. I can hear that. Can you hear that? Yeah. You just do it with your fingers. I can be able to hear this. Be able to hear that.
It's vestibulocochlear.
Hmm?
You say it vestibulocochlear.
Thank you.
You can tuning fork it,
Yeah.
just to see. People actually, we really do use the tuning forks.
Yeah, that's
Like,
what I.
it's one of those things that you
grabbed and used.
when you're in school, you're like, I wish people don't really ever do that. We actually do it. I do. A lot of times I confirm, like what I'm seeing on an audiogram. If I'm trying to figure out if something's conductive versus sensory neural, I use the tuning forks. And it also can determine if we're going to do surgery, if they flip a fork, those kind of things. So those are important exams that you can do.
Are we gonna do Snellen?
No. No, we won't have to worry about that.
So
we
we're
don't
testing.
have a wall chart, and I don't know if they have handhelds.
We have
in there.
handhelds.
Yeah, I
I
think they
mean,
have
everyone
handhelds,
does,
but
but-
again, since there's gonna be a running clock, that would be time consuming,
Yeah.
so, if someone happens to be coming in and they're talking about, if they have something that has any sort of visual disturbance associated with it, so I would say probably a migraine, patient, or uncontrolled hypertension, and they're having neuro exams, certainly, and I would at least say if they have any sort of, if they're complaining of headache, and you say, do you have any blurred vision or visuals, if they say yes, then at some point during your assessment, you would say, hey, I would have had the MA have them read the eye chart before they came in the room, or I would hand them a Snellen, you know, to do, but because of the running clock, we're not gonna eat into that. Alright,
What's now the Snellen eye, would that be specific to cranial nerve one?
now, cranial nerve 1 is olfactory. Right.
Smell.
Okay.
So by testing the optic, that was the peripheral.
So doing peripheral, also pupillary response, right, with the light. Yeah, you gotta have something to really stimulate the fundus to be able to check that box, right? So you gotta have pin light or use one of your scopes, okay? All right, what else? All good questions.
Confrontation. I'm trying to, that just went blank in my brain, as far as the eye exam
Mhm.
goes. And so like when we're using the right lingo, the right language, medical language, when we're
So
testing
like
each one of these nerves.
Confrontation, accommodation, right? But one of the main things that we're primarily checking for is the presence or absence of nystagmus, right? We have two types. We have horizontal and we have vertical, right? Which is the more ominous?
Horizontal.
Vertical. Okay.
Vertical. Usually always neuro if you have a vertical nystagmus,
Right.
for sure.
So the person goes, they're looking this way, when they would go that way, that eye goes fast, one of,
So the best, no, so for horizontal nystagmus, and that can be caused by a variety of conditions. A lot of them not even related to the eyes, the inner ear. Or medications for that matter. It looks like an old-fashioned typewriter to me that skips. It's just, you see this, right, on a horizontal plane, okay? If you see vertical nystagmus, that's an ominous, that's a, hey, Houston, we got a problem. That's usually a brain lesion of some sort, a lesion or mass of some sort. A lot of times, especially if the gaze goes up and gets fixed to one side, that's kind of very, very ominous, because they usually will do that to the side where there's a not so fun mass or something going on. So horizontal nystagmus can be expected depending on what's going on. The degree of it is kind of what you're tracking and looking for, presence or absence, and then kind of to what degree. But vertical nystagmus should not be there.
so you can just say no.
Cause I have nystagmus, my eyes will go this way a lot.
Have you ever met somebody with congenital nystagmus, where they just can be sitting there just looking at you and their eyes are moving the whole time? It'll freak you out. I mean, it's just like constant. So then you talk about trying to do a Dix Hall pike on somebody like that to try to figure out if they have benign positional vertigo because their eyes are already all over the place. You're like, I don't know.
Oh, yeah, sorry, you brought up a
Yeah.
thing, yeah, you guys should be responsible for Dix Hall Pike, exactly, like you said that. Dix Hall Pike, I don't think it's in your book.
Does anybody know what it tests for?
And it's called when.
Good. Benign paroxysmal positional vertigo.
Yeah, Dix Hall Pike. So again, because of time, we wouldn't do it, but if you have somebody who's coming in talking about any sort of dizziness, or room spinning round and round, or being off kilter or whatever, at some point during your neuro exam, we would expect you to say, I'd also perform Dix Hall Pike maneuver on this patient.
Can you spell that so I can?
DIX-HALLPIKE.
Okay, sorry.
I will tell you that is
Say that
probably one of the most DIX hyphen.
Hall pike.
Hall pike.
Yep.
That is probably one of the most missed diagnostic exams that family nurse practitioners and or physicians do not do. I can't tell you how many people go to the emergency room for benign positional vertigo and spend thousands and thousands of dollars on a neuro workup because they're thinking they have a stroke, they're having a stroke, and it is their crystals are out of place. That's all it is because people choose not to do a Dix Hall pike. Your most common nystagmus with a Dix Hall pike is a rotary nystagmus. So it's like if the right ear is causing the problems, when you lay them back, their eyes are going to beat down in a circular fashion towards that ear. Okay. You'll also There's a different way you do it to test for a horizontal canal BPPV, and that is horizontal nystagmus. Like, it is just side to side. But the rotary nystagmus is usually what you see. I mean, and it really does look just like that. When somebody comes in complaining of dizziness, the first thing you ask them, describe the dizziness without using the word dizzy. If they can tell you they are spinning, that the world is spinning around them, you should do a Dixhall Pike, just to make sure that those crystals are in place. Dizziness that is not room spinning vertigo is likely not the ear. It's likely something else. If they're lightheaded, cardiac. Look at your cardiac. There is vertigo though that can happen with migraines. Okay, but
Just do a migraine.
that's when you basically, as a family nurse practitioner or whatever. I know there's only 3 of you that are on that track. Your job is to figure out what's wrong so you can know where to send them. If you can't fix it, you know where to send them. So you know this is an appropriate ENT referral. We get every dizzy patient. If a person comes in and says they're dizzy, they're going to ENT. But if you would just ask them the right questions, you might be able to avoid ENT and send them to the neurologist like they actually really need, and save that patient a whole lot of time and money by sending them.
And you
to
guys
where
on
they
the
need
psych
to go.
world, while you're talking to your clients
lots of
on your
dizziness.
appointments, you can see you're able to obviously see the eyes, and you can see if someone say that they look down or they look at their watch or they look at something and they come back up and you see a bunch of nystagmus, hey, that might kind of cue you off. Or if they're or looking around the room, looking over their shoulder, and then they come back from looking this way for a moment or two, and you see a bunch of horizontal nystagmus. All right, that's something that you kind of maybe just I need to ask them about this, what, and the other, and refer them someplace, right? So any changes that are provoked by changes in body position or head movements is another thing that can trigger some of that as well. So if you have to at the end of the visit and they're going to get up and you notice a sway and you look at their eyes, right? There's a lot of stuff that you'll be able to pick up on neuro and ENT wise potentially without laying hands on them, just from looking at changes with head movements and body positions. All right, any other questions about that system?
Ear exam, my ophthalmoscope and otoscope, was a nice $75 purchase. It's a piece of crap equipment. And then, patients in the NICU don't have this at their, and then I went to a couple of units and theirs were dead. I'm like, how does anyone
They don't.
do these exams in the hospital?
They don't.
The ENTs usually bring their own case,
they
bring their own equipment.
So with this being super, would I be able to see more? And is anybody?
Oh, you mean for the eye? It's not just for the eyes,
Well,
right? That-
Yeah,
it is-
and ears,
it's not
like
gonna be-
I was looking in my husband's ears and everybody's ears, and the only thing I can see is wax. I mean,
Okay.
and I know
Then
everybody
you-
has waxy
Then you
ears.
would say unable to visualize the TM due to a cerumen impaction. Okay.
And then you do not diagnose an ear infection when there is a cerumen impaction.
But
You
then-
cannot see the eardrum.
But then on Shadow Health, they have all these amazing things that you can see and need.
That would be in their clinic because they have the amazing
And
equipment.
I'm like,
This is
okay.
not going to, this is
I
not
have my
going to
own otoscope at
reveal.
home that I never use because I've tried using it and it sucks. I will bring it from the office. If, my neighbors like to look at my kids' ears, I'll bring one home because they're just so much better there. But we use a lot of, like ENT, we use a lot of microscopes. I use a microscope to look at almost everybody's ears because it's just so much better. The older I get, the better I like that microscope because I can really see. If I can blow anything up real big in that regard. But pet peeve is when kiddos are getting diagnosed with ear infections all the time. They've got wax impactions. Nobody's even seeing their ears.
Yeah,
And
mine
they're-
is full of wax.
Yeah.
I need to go.
Don't use
have my
Q-tips.
ear.
And so, hairy ear hole is not properly.
Hairy ear
defined.
holes suck. I got a lot of ears, hair in the ears with the little old men.
I hope that's not me. I hope my daughters
No, they have.
take care of me when I go.
So, but how would you chart that? Is it just
How would you?
Unable to.
Be honest, unable to
How would you
visualize the
visualize
TM due to
excessive
amounts
amount
of hair in the, or hair in the ears, or
So you really can't
excessive,
say something.
excessive amount of hair
I'd say stuff like that.
obscuring the external ear canal.
probably uncooperative, like with kids, no matter how much you papoose some of them down or hold their head,
You
like,
just can't do it.
you sometimes cannot see, and I will document that. Or if I can't get a foreign body out of their ears and we have to send them to surgery, you have to document exactly what happened. This is why we're sending them to surgery, to get this bead out of their ear, because we couldn't restrain the child, you know what I mean, in order to get it without causing an excessive amount of pain and trauma.
Okay.
Be honest in your exams.
What else?
Can we review those, the musculoskeletal exams that you sent the videos, or just one or two of them?
Which one or two out of the 30 plus?
Maybe the people that weren't here, just, or something.
Like I said, the Austrian guys do, I think, a much better job than what I do.
I did have a question about like some of the tests.
Yep.
Are you doing like both extremities or only the one that's affected?
So here's the thing, in clinic, yes, you do the affected to the unaffected. Again, due to time constraints, we're just going to work on the affected. But you should verbalize something. Hey, I would also check out the left knee as well if they're there for right knee pain. But due to the running clock, we're kicking some stuff overboard for time, okay? Because I don't wanna cut into your, to that, okay? But as long as you verbalize and know, yeah, hey, I would do the affected and the unaffected, great, we're good, okay?
I do have a question.
Yes.
So I know you mentioned we should have like one page for notes and then one blank page.
Mhm.
Will we have to present something at the end in terms of like our
Yeah,
findings?
so here's the thing, so ideally, throughout the course of your exam, right, and those of you that have been here, you guys have heard this already, but ideally, as you're going through, you're verbalizing all of your findings out loud as you go, right, to us. That, one, lets us know that you know what you're doing and what you're assessing, and we're able to easily track that. Two, it keeps us from having to interrupt you during your exam, because again, adrenaline's flowing, nerves are high, and we have had some of the absolute, we've had people who have been totally silent, and they are, just finished looking in an ear, and they've not said anything for the last few minutes, and we'll say, okay, tell me what you just did, what you just saw. They literally will have just pulled the otoscope out of the ear, and they'll turn to us and go, I don't know. From something they just did 5 seconds ago. So, because they're just so nervous, and we've thrown you off of
I
your.
do that in my exam, because I'm talking to the patient, when I'm looking at them, then I'll be like, did I look in your ears? And they'll be like, I think you did. Well, let me relook.
So, if you're verbalizing everything as you go, it's clear for us on the grading sheet. We're not having to interrupt you. If you're completely silent, then at the end, we're going to make you rattle off everything in order. And again, because of adrenaline and nerves and all that, trust me, if you don't remember what you just did 5 seconds ago, how are you gonna remember what you just did 30 minutes ago? Okay? So ideally, you're calling all of this stuff out as you're going, right? With proper medical terminology, and, right, hey, I'm gonna assess, I'm gonna start my ENT assessment, I'm gonna start with the ear, I'm gonna manipulate the external structures of the ear, manipulating pena and tragus, I don't see any otorrhea from the external ear canal that I can visualize, I'll put my scope in. Yep, canal looks clear, no erythema, no debris, no otorrhea, no cerumen. I can visualize the TM as a good conal light reflex. It's pearly gray. I can make out my bony landmarks. That's what you're, as long as you're going through all that, boy, that's just clear, concise. We aren't interrupting you. You're doing your thing. It's whenever you get thrown off of doing your thing when the wheels tend to come off, and people, like I said, just absolutely have amnesia. You have no clue what you just did 5 seconds before.
When on our blank piece of paper, are we during the exam writing out our
You don't necessarily have to.
So
But
how
can-
do we perform
As long as-
HBI?
So HPI is history of present illness, right? That is, that comes after what? What's our first thing that you're gonna
Chief
have?
complaint.
Chief complaint, right? So you're gonna get a complaint or complaints, okay? So your HPI, these are the questions that you're asking to get more information about the chief complaint or complaints, right? Quality, characteristics, using, whether you wanna use the old CARTS acronym or whatever it is that you wanna do, you're working on all that, right? Then we're reviewing past medical history, past surgical history, if it's not already comprehensive and given. You may get some elements of it, but don't assume that it's all comprehensive. Then you're talking about, so we got past medical history, past surgical history, social history, family history, allergies to medicines or medical products, medications, over-the-counter vitamins, supplements that people won't necessarily consider medications, and then your ROS, okay? So your HP, all of that stuff you're going to be just verbalizing. If you're asking the right questions,
So we can say it
And
out
you're-
loud.
you can say, hey, so I wanna get some more information about this, about your chief complaint. So let's kinda talk about the history of this, of this illness. How long has your ear been hurting? How would you characterize the pain? Have you noticed any, that stuff you're running through and you're verbalizing. If you wanna write it down, that's fine, it's gonna just take time, but that's stuff that, we should know, So as long as you kinda say, and as long as you make, nice smooth transitions, all right, now I wanna talk about your past medical history. It says here that you have, high blood pressure and high cholesterol. Is that it, or are there any other issues? To get clarification on that. Past surgical history says you've had a hysterectomy. Is that total or a partial hysterectomy, right? Let's get some more clarification on that. Any other procedures that you might have had, where you didn't necessarily spend the night in a hospital, because like I've said all along, patients are stupid. A lot of patients don't consider something a surgery unless they spent the night in the hospital. There's lots of stuff that we do outpatient now that don't require overnight stays. Lots of stuff, major surgeries, right? But if they don't spend the night in the hospital, they don't count that as a surgery. And that may be something that's applicable to what's going on especially if you have someone who has a chief complaint of abdominal pain, right? If they had a previous cholecystectomy and they had that done, outpatient, it's a 15-minute thing, boom, boom, done, out the door. They're saying they're hurting up in the right side, and you're saying you got a positive Murphy sign, but you didn't ask them about past surgeries or procedures, and there is not a gallbladder there. That's a problem, right? So, making sure that you qualify all that, make nice little transitions. And let's kind of talk about your social history. It says here that you're married and you're an aerospace engineer. Any alcohol use, and if so, you quantify that. Any tobacco use or vaping or recreational drug use, right? Let's talk about your family history. If there's not stuff given, we aren't getting deep. We're just doing mom, dad, siblings, grandparents. Okay, first degree relatives primarily.
And you will have a person that will respond,
Yes.
so you can ask
Yes.
questions and.
If you don't ask the right,
patient
if you
will
don't,
say
if you don't ask the right questions, they ain't talking to you.
Or some of them you'll ask them and then they'll go,
But you have that in practice. We've talked about the examples before of talking about, male patients who don't wanna say anything. And then you also get some patients who it's diarrhea of the mouth. And you have to be able to learn to take control and direct and steer that exam, okay? Nicely.
And it's like, that is one of the problems that I see, like I teach at Walden also, I'm teaching in master's classes. So I always tell the patients, the students, when you give me a chief complaint is not some long drawn out stuff. It is a simple statement of what you're here for. Like, I may have anxiety, boom, that's all you need to put. HPI is just simply, what are you coming to see me for today? What is going on right now? I don't need to know about, and I'll see there are notes that they've got all this stuff that they was married. I prayed one other night, I was like, oh my God, she was married, she did this, she did that. That is not what an HPI is. HPI is what is going on right now. You can make this very simple. And then you go to the neurovegetative and you solve the sleep and the eating, and you just go, you keep going, and then you get to the social history, and then you drink, smoke, and all that medical history, allergies, medications, current medications. But if you send something to me, chief complaint, I just want to know, what is that chief complaint? What one simple statement, put it in, and then that HPI, what is happening right now? Why are you here now? And then subjective, objective. I don't know why that is such a big problem, but subjective is what they tell you. Like, when you do it, I have had a fever, I've had this. Objective is what do you see when you start doing that exam, when you're going through there, do you notice any rashes? Do you notice, when you're listening to lung sound? So always know your subjective and objective, and just, some people are making this hard. It's not, it's just simply, what the chief complaint, what came in, HPI, what's happening now, and then you just go down. If you just go down your little list, you'll get everything, and you'll be fine.
Touch on that ROS.
The
Touch
ROS,
on
the
ROS.
HPI is subjective, right?
Right.
The exam is objective. It's what you find.
Other stuff will come out in the ROS. Sadie was with me in my clinic today. This week, how many encounters did we have where people just gave us one thing or one thing only, and I'm good?
Not one.
Everything was, I'm here for this, but we also uncovered that we had to address and work up, right? It was not just, just whatever, and that's all I'm here for, and I'm good otherwise, right? So we start going through the ROS, then we start pulling out other stuff, and then all of a sudden I have what they signed in for, checked in for, is now half a dozen different things that are being addressed. Okay.
On like musculoskeletal, the Sperling test,
Mhm.
I know that they turned their head slightly, and you're kind of pushing down on it.
So there's,
Which way are you
so
turning?
it depends. So we're
Okay.
initially assessing, we're neutral position, right? This is Sperling's is for someone who's coming with neck pain, and we're assessing for the presence or absence of upper extremity what? Radiculopathy, right? Numbness, tingling, burning, shooting pains coming down. We're trying to recreate that or create it if it's there. So we start neutral position, spine in neutral alignment, mash down on top of it, and you're asking the patient, hey, I'm gonna put my hands on top of your head, I'm gonna push down on your neck real quick, and then I'm gonna let go. I want you to tell me when I'm doing that if you feel any numbness, tingling, burning, or shooting pains going down either arm. And also, if you do feel that, let me know which arm and how far down does it go, okay? So if they say, yeah, that just lit me up over on my left all the way down to my forearm, then you want to isolate each side. So then I would say, okay, about 30 degrees, tilt your head over to the left, and you do it again. You're isolating that side, and they, oh yeah, that really got me that time, and it went further down, I felt that all the way down to my fingers, okay? So if you have a positive finding in neutral spine position, then you want to isolate to whatever side was affected. If they say it lit them up down both extremities, then you would 30 degrees to the left, boom, 30 degrees to the right, boom. Okay? And you're tracking how far down that travels. So neutral first, side to side, depending upon what your initial findings are. Hang on for me, this is my police chat. I'm gonna make sure there's nothing going on. Okay, what else?
For the hip, it was just the Faber test, right?
So for hip, you guys are doing, I'm having you do Faber and Favors. Faber is on the back, supine position. They are in this type, so if it's right hip, right foot on top of the knee. You're trying to get them to lay this leg flat onto the table, right, okay? And seeing if there's any pain. Typically, a lot of times, this will cause pain through the groin, and a lot of times we'll let you know if this is more of an IT band or flexor tendon type kind of issue as opposed to directly into the joint. And also, while they're on their back, we're bringing knee towards the chest, and that's the windshield wiper test, where you're rotating in and out, kind of like a windshield wiper, internal and external rotation. That's faders, okay? So Favors and faders, okay? You can do a
Fader.
You can do a modified femoral adduction and internal rotation on faders. You can do a modified one if they're sitting, or if they are morbidly obese and can't lay down because they'll go hypoxic on you or something like that. You can do a modified one here just by coming up here, and I can internally and externally rotate in a seated position, but ideally we're supine for that. Okay, but that's all you guys are responsible for on a hip at this level is for any provocative testing is fibers and then faders. And then having them walk at some point, right? You're needing to do that.
So as far as the scenarios, will we get like a patient chart, or it would be something written? with the chief
You'll,
complaint?
yeah, no, we'll give it to you. We'll give you the bullet. The patients will have their,
I'm sure we read you the
yeah,
scenario. There were like vitals on the wall.
we can, because we can run on these walls. There'll be
That's why
vitals
you
and some
take
other
notes.
stuff.
So when we're saying this patient was, no, it's like,
We'll say, hey,
39-year-old patient here for evaluation of dizziness. It won't be dizzy, but dizziness, right? And then we'll give you a little bit of history. That's where you can use that paper to jot down some pertinent information, so then you can ask whatever questions you wanna ask.
it won't be
That's a
comprehensive.
separate sheet from, separate.
Yes.
You have your cheat sheet, you have a blank sheet of paper for notes, right? So there'll be some stuff up on the wall and then some stuff that we tell you. Because we have rotating patients, so it's not like we can just have fixed stuff. I mean, our stuff is specific to the patients.
When will we sign up for these?
I will open that up tomorrow.
And then do we need to be, does everybody need to be here at 8:30, or we just show up at our designated?
No, actually, we're gonna start at 8. We'll be the first sign-up slot, so you show up at your designated time. I would show up just a little bit early, right? We tend to actually run a few minutes over for whatever reason, but every now and again, we get a block that we get done in time and we're able to go along. So you guys will be out in that lobby area across from the classroom that we were just in. And then when an instructor's free, we come out and grab you. It's a 30-minute slot, so we'll have an 8 group and then an 8:30, 9, so on and so forth, right? So it'll just be whatever instructor is free is gonna come out and grab you and bring you back, and you'll hand us a grade sheet in your folder to look at first, and make sure all the stuff's in there and squared away. We'll review your cheat sheet, and then say, okay, and then we'll say, we'll be running a clock. We'll ask you if you want us to give you countdowns or not. Some students prefer for us to give them time hacks when there's 10 minutes left and then 5 minutes left or whatever. Others are like, yeah, don't do that, it's gonna freaking frazzle me or whatever. And then we'll say, all right, so here's your scenario, 37-year-old white female presenting with da-da-da-da-da. Past medical history includes this, medication includes this, we'll give you a little bit of info, and time starts now, boom, then it's on you, right? And then you run through, majority of people get done with lots of time left on the clock, okay? So, when you're done, you will say, okay, I'm done. We will ask you, not because we're trying to mess with you, we're going to say, hey, there's 11 minutes remaining. Are you sure you want to be done? We're not saying that because you have missed something. We're not saying that because we're just wanting to acknowledge from you, get a verbal response that, hey, there's still time left if you think you need to do anything else, but if you got it and we're good, you say, no, I'm good, and we're done, all right? So don't think that we're trying to trick you, okay? We just want you to be aware, hey, there was still some time left on the clock, and you can go back and, do anything or whatever, so don't start doing crap for the sake of doing crap at that point though, okay? If you've covered everything, because we've seen this too, we tell students, and they go, actually, I think I need to do, and then they start doing stuff that has nothing applied to the scenario. Well, we'll count off for that, right? This is quality, not quantity, right?
Every scenario is different.
Every scenario
three coming back, all three of you would have a different scenario. So
Every patient's different, just like
so if
every
things went
patient's different.
bad.
Things
you're gonna
go
have a
bad, and
totally different
if
scenario
things
for
go
sure.
bad and you have to retest, we do that after we've run everybody through the first time. And then, yes, you would have, a different patient, and you would then have two instructors grading you on the second attempt. Would be how that goes, and then we average the first and second one together, and they gotta be above 80.
Oh wow, so you'd have to be perfect, pretty much, second round.
Depends, I mean, if you got a
70.
70 the first go
Oh,
around,
that's true.
then, you know.
You could just barely be in.
Now, if you,
Don't,
now,
don't forget those clinical folders.
Yeah.
So like with your e-clinical.
Yeah.
Like, so we can see how those, like, you don't have to upload the e-clinical, you know, in
Your
the
e-logs.
assignment tab,
There's
so I
something that
keep trying to
says
figure out those
e-logs.
e-logs. Like, just send, like, bring them.
I'll cover that in my weekly updates.
You want the
tomorrow.
hard copy?
Hard copies.
Okay.
You will be handing your
You
folder,
don't have
you
to
will be
check.
handing your folders over to us, we will keep your folder.
Whenever you do the update, will you put like on e-logs, there's various different things that we can go into, cause like
It's the
there's one
summary, it's a summary
that gives you like
report.
the full narrative that you typed, okay,
Yeah, no, all we want is the summary of clinical hours.
okay.
That's it.
That gives you the percentages spent on
Yeah,
like
that's
males,
it.
females,
That's
age,
it,
okay.
it's just a couple of sheets.
Yeah, and if you're in my section, like, I've been trying to keep up with the grades, like for your shadow health and all of that, if you see any mistakes, then let me know. Cause it's a lot.
All of y'all have been doing
Like,
fine on the show
Yeah,
health
so
stuff.
I mean, I'm just if you see something's wrong, please let me know.
Same here. I grade like late at night, and so I go back through. I tried to make sure that everybody was updated. It looked like everybody was pretty much on track. On as far as the logs and stuff, I have sent some of y'all an email like, did you do 9 hours? Did you do 10 hours? Because it's you're not very clear with me. So just tell me, and then again, I will be able to see all that on the logs, but when we check them off. But so if you grade, if you see that you're missing something, it's not that I'm ignoring. It's just that I'm a late person. I stay up late, and so like I said the other night, I went in and added, updated, as you guys are doing the cardio or whatever.
Your e-logs has got, equals 64 hours, right?
When is the last day for completion?
Of clinicals
Yes,
would be Friday.
next Friday.
Yeah, 'cause if you don't have your hours done before Saturday, then you can't do your checkoff. You can't do a checkoff, you don't pass class. Right?
So on your rapid, you did the fingers, but like Shadow Health, like did the,
Fine, rapid
That-
alternating movements, hands on thighs, back and
That's
forth, back and
fine.
forth. There's
We
no
can do
need to,
whatever
there's
we
no
want.
need to do redundancy, you can pick one or the other, right? Okay.
and then with the
Yep.
hands out like that and close your eyes, the
Mhm.
whole nose thing would suffice to
Good, yeah.
replace
Several,
that.
several different ways that you can knock out a Romberg if you want to. Again, what works for me may be different from what works for you, whatever.
Okay, so are we gonna start with scenarios?
Oh, that's what we want.
Yeah.
That's what we want. Alright. Sure, I'll run through a scenario.